welcome members, having had that few weeks break. We did schedule to have meetings on a couple of occasions, and for one reason or the other, we did not have the full quorum. And so I would like to just state that for the record. We had to make some adjustments in terms of some of the days because of some other emergencies, many of which were related to COVID actually. So the meeting could not have taken place. We're also back to our parliamentary space, you know, I was enjoying the Zoom meetings, I must say, but being the Democrat that I am.
Chair, I'm not aware it was ever put to any vote as to whether we should have to come here. This meeting was specifically set up with our authority to meet by electronic means, and we were doing quite well with that. One or two members perhaps never attended. That's their choice. And you know, I think we need to get to the point where we can have these sorts of meetings electronically like the rest of the world has been doing, rather than exposing ourselves and staff to unnecessary risks, especially since we've been functioning quite well that way. Yeah.
Thank you for that input, member, and I must say that I very much agree with you, and maybe one of the things that should happen over the next few days to the next meeting is that we send around a circular and ask for members' opinion on the Zoom as opposed to the physical presence, because I certainly thought it was working, and I thought it was a good message to send actually to the population in keeping with the need for physical distancing while still conducting the affairs of the country. So symbolically, I thought it was powerful. But there were one or two, at least two members, two of whom are looking at me right now as we speak, who had issues with it. And I didn't want it to be said that we were somehow keeping them out of the conversation. But I do believe that it's something we need to think about. So maybe with your agreement, I'll send around a circular. And if members have issues, happy to try to accommodate those issues.
Chair, let me comment. Good morning, members. Good morning, PS. Good morning, CMO and staff. I am one of those who...
Sorry, member,
Yeah.
not to disrupt you, but
We
you
didn't
know,
have a
we
plan.
normally say prayers.
Yeah, we didn't have a, I just say it.
Okay.
Almighty God, by whom alone kings reign and princes decree justice, and from whom alone cometh all wisdom, counsels, and understanding. We thine unworthy servants here gathered together in thy name, do most humbly beseech thee to send down thy heavenly wisdom from above, to direct and guide us in all our consultations. And grant that, we having thy fear always before our eyes, and laying aside all private interests, prejudices, and partial affections, the results of all our counsels may be to the glory of thy blessed name, the maintenance of true religion and justice, the safety, honor, and happiness of the Queen, the public weal, peace and tranquility of the island, and the uniting and knitting together of the hearts of all persons and estates within the same, in true Christian love and charity, one towards another, through Jesus Christ our Lord. Amen.
Amen. An indication of a very long-standing member of the lower house.
I've never heard anybody say that prayer by heart.
You serious?
Yeah.
Excellent. Very good. Can I just for the record, before the member speaks,
Water, that's why.
just recognize member Malahu Fort, who said she would be late. And just for the record, please. Okay.
Yes.
You were saying?
This committee was established, but had the authority to meet by Zoom. It was as established to meet by Zoom. We had the authority of the House that we can meet by Zoom. And my objection has always been, the House was meeting with 63 persons. Other committees were meeting here and practicing social distancing and so on. And therefore, I felt the committee could meet in Parliament. I have had several Zoom meetings during the period of the heights of the COVID, and these Zoom meetings still continue. And it's a good message to send, I agree. But the PAC meets right here, our chairman is sitting right here. The PAC meets, reluctantly, the PAC meets, all other committees are meeting, and I felt that this committee ought to have been meeting here unless there are extenuating circumstances that we say we'll have a Zoom meeting. And I have no difficulty with that. But to just have total Zoom meeting when I can't see the reaction of other members and their faces, and I like it. I like to be in person. So that I am one of those who objected, and I just want to clarify why I objected.
I just would like to tell the member that it is possible to see the faces by Zoom. Maybe the technology allows for that, and maybe Zoom could be accompanied by a very simple protocol in terms of some of those concerns that you have. But I still maintain, as I believe the member who spoke prior to you said, that there is value, given what this committee is about, and given the fact that we are still in the midst of a public health challenge with COVID, that we chart a different course and demonstrate an approach that allows the country to function while we engage in the kind of protocols that we are promoting in the general populace. I see a lot of value in it, frankly speaking. I see Member Dalrymple Filbert and then Member Brownberg.
Thank you very much, Chairman. First of all, I want to apologize, but I'm coming from the country after getting over, and there was just more traffic than I expected. I agree with you also that there's a lot of merit in the Zoom meetings, but I'll tell you one challenge some of us have, like myself, and I'm not in South Trelawney when I'm there, I'm in Runaway Bay, and very often the internet system goes down. So you're in the meeting and you lose 15 minutes of it, you come back in. When you're through, sometimes it's almost as if you have not really been a full part of the meeting and grasped or been able to participate as you would like.
Thank you, Mr. Chairman. I'm one of those. I try to make it to the Zoom meetings, and I agree with you 100%. That it does send a powerful message. And I think more and more people in other spheres of life are finding that this is a way to do it. And it is effective, and it really is if it can be done. So, I mean, I don't have an objection to it. My issue is, I have two main issues around the meetings. One is, I just felt that if we're meeting here in Parliament, we'll be closer to starting on time most times. The start time. I want a better predictability in terms of the start time. And even where we end up starting late, because I understand the exigencies of the office that you hold, I believe that just so that we know. Yeah, I don't want to be sitting for 20 minutes not knowing when we're meeting, you know? I want a little certainty in terms of where we're starting. So send and say, well, we're running half an hour behind, I am good. So that's one. And secondly, I know we have been doing a little better in more recent times, but one of my big issue was the documentation. Yeah? We seem to have been doing better towards the last couple of meetings, but when I find that when we're here, the presentations that I made, we get them. That wasn't happening. And so I had a big problem with that. And you know, I keep saying that I am a visual learner, right? So I want to see it, you know, kind of thing. And those were the two concerns I had. If we can deal with those two concerns, I would have absolutely no difficulty continuing with the Zoom meetings.
Just to say, member, that I fear that your two reasons for not having Zoom is an abuse of the Zoom process, if I may, because those are more administrative issues that I think are duly noted and quite valid if once those concerns are consistently an issue. But we could easily address those and benefit from the other greater good of this signaling and the messaging. So I think, and by the way, I was early this morning, you were late. But just to close on this point, what I would propose, I'd like to send a little note around before the next meeting and just get some comments from members as to their willingness to re-engage. It could be a case where we do both. You know, if we meet twice a month, we do one Zoom and one in person, just to maintain that sort of important symbolism. And then what are the other administrative issues which clearly wouldn't be the fault of Zoom, it would be the fault of us. And we should sort that out. Circulating the information has to be a function of both the parliamentary administrators, but also my office. And therefore, if there are issues there, I will seek to deal with those issues. I think we were late once or twice, but not all the meetings, but that's another issue. We can correct those also. So thank you very much for that.
No, Chairman,
Member, you have a comment on that?
It's unusual that I don't have a comment. My only concern, Chairman, and I will work either with an in-house meeting here or Zoom, my main concern is for whatever reason, infrequency that we have been meeting. Our last meeting, I think, was on the 28th, on the 19th of May, which is almost 2 months, well, 6 weeks ago then. And usually we had agreed, probably in principle, to meet on a weekly basis. So that's just my concern. And I understand some of the reasons why, but it's just that this is an important area, an important matter facing the country, and I think that all efforts should have been made for us to meet on for want of a better word, a more timelier basis.
Right. So I appreciate that comment. The meeting we were meeting on a regular basis, except for this fairly lengthy break due to, as I said, a number of issues, including members not being available on the rescheduled dates. There are at least 3 occasions where members were not available when we rescheduled. So happy that we have most of us here now. We can convene, but the decision as it relates to Zoom versus Parliament will be determined on a little circular being sent around with persons making comments, preference, what would be the issues that we would have to overcome to have that done. Thank you. So we move on to the next agenda item. Well, we've gone through welcome and opening remarks, and we go to the minutes. So can we just quickly run through the minutes, and then after which the Chief Medical Officer will go through a presentation that is up on the screen. So as usual, I ask you if there are any issue that you're going to raise relating to the minutes, and you think it will be addressed in the presentation, maybe we could hold until then. I want to just say, however, that apologies for the NHF not being here. We did agree at the last meeting that at the next meeting the NHF would be present. For some reason, they were not notified with sufficient time. So what we will do is program the NHF's attendance at the next meeting. So I apologize to members for that. All right, so the minutes are before us of Tuesday, May 19th.
Was the NHF advised?
Late.
Late, okay.
Yeah. Right. Yes, it's not their fault. All right, the minutes are before us, May 19th, 2020, page 1, page 2, page 3, page 4, 5, page 6, page 7, 8, 9, page 10, 11, 12, and final page 13.
Chairman,
Yes.
can I crave indulgence to go back to page 9? I know
9, okay.
the clerk was feeling quite elated that there were no corrections, and I still want to commend her on this particular one because we have not had any. Just an omission. I think on page 9, reference to Ensom should have been
What
Ensom
paragraph?
City. Oh, it's the third paragraph from the end of that particular page. Waterford and Ensom. I think it's Ensom City that the place is known as.
Okay. In some city. Okay. All right. So if that's the only correction, then may I ask for the confirmation of the minutes?
So moved, Chairman.
Moved by Member Guy, seconded by Member Brown Burke. Thank you very much. And then we go into matters arising. If there is a matter again that can hold until the presentation, it may be more useful for the conversation. So otherwise, are there any matters arising from the minutes? No? Okay. So can we go right into the presentation then by the Chief Medical
No,
Officer?
Chairman. There was
Okay.
a matter that came up at the minutes at the last meeting on page 8 that we would ask that the representative from the health facilities and monitoring unit should submit reports every 2 weeks as opposed to reappearing before the committee to provide an update. We have not been in receipt of any such reports and would like to know whether it will be covered in the presentation here.
This is in regard to nursing homes and,
Yes.
and
Yes, Chairman.
well, let's hear from the Chief Medical Officer, but I could ask the PS to do some inquiries to see if there's any additional information beyond. But we'll note that also. Any other matter? Members? No? All right. CMO, you want to take over from here?
I don't think that might.
Is this on? Yeah, I'll just use this one. Oh, that's fine. All right. Morning, everyone. Thank you for having us here, Mr. Chairman and other members present. I want to apologize, first of all, because the slide set that you have is dated the 29th of June. The slide set that I have is dated the 1st of July. So there would be a slight difference in the numbers. Is more updated. Okay, all right. But just to look at the numbers as of yesterday evening, we have 702 confirmed cases now. 187 are imported cases. Still remain at 39 cases of local transmission. It's important to note here that for the entire month of June, we have had no local cases. All the cases that we've had would have been import or import-related cases. We've had 233 contacts of confirmed cases. still remain at 236 that were related to the workplace cluster in St. Catherine.
Sorry, Chair. Same, just to say that something was sent out last night that were at 707 cases. That was,
okay, so this would be today, this will be the 1st of July's report.
Okay.
So we would have been updated for the results that came in at 3 o'clock yesterday.
Okay, this was
so
after
which
that.
would have been the 5
All
cases.
Right. Okay, cool.
Right. So 236 related to the workplace cluster, 7 under investigation. So essentially for this, it would just be 2 categories that would go up, which would be the 707 and the 187 imported, then 5 would be added to that. Okay. What I have again is from the yesterday, where we had 24,501 tests performed, and that had put us at a 2.9% positivity rate. Okay, so the next slide is a summary slide, and pretty much all the other slides that follow after this is really this slide explained. So I don't have to go through all of the 28 slides that are here. I'm just going to focus on this slide so that it's in the interest of time. So essentially this looks at our surveillance, the different surveillance methods that we have had over the time, and to indicate that through contact tracing, case investigation and contact tracing, we've had our highest positivity rates. In fact, we have tested 4,045 persons that have been found through contact tracing, and we've had 467 of those that have been positive. Respiratory surveillance is another area that we would have a reasonable pickup rate, and for this we would have a 1.3% positive rate. We have tested 3,641 persons who would have presented to our facilities across the island with some kind of respiratory infection, whether it would be influenza-like illness, severe acute respiratory illnesses that have been admitted to hospital, or admitted lower respiratory tract infections. And that would have given us 47 positive out of 3,641, a 1.3% positive rate. 47, right. In terms of our general hospital surveillance that we started in May, again, we have here 0.3% positive rate. We have tested so far 344 persons. We had started off with a phased approach in terms of the hospital surveillance, where initially we would have started with all persons in ICU, high dependency areas, persons that were being prepped for surgeries, and then we would have moved on to persons with any kind of depressed consciousness, severe illnesses, and then we were to move on to our over 60 age group. But so far we have tested 344, and we've had 1 person that has been found to be positive. Sure. Mm-hmm.
General hospital surveillance, do we have a breakdown? You said you have done 300 and odd. Do you have a breakdown like at KPH, at Maypen?
I don't have a breakdown per hospital, but we can get it per hospital. What I think I have in this should be the breakdown by the presentation, what was sampled, and that is on page, should be on page 11, may not be updated. So most of the persons really would have been the immunosuppressed patients that were sampled and patients that were pre-op. But I don't have the breakdown by hospital, but we can. It's general hospital surveillance. So in terms of the surveillance of the communities, so we have surveyed varying communities.
You hadn't done the healthcare worker surveillance numbers.
Oh, sorry. The healthcare worker surveillance, we would have tested so far 502 healthcare workers, and we would have had a positive 8 persons, a 1.6% positive rate. So these persons would have come to attention because of various reasons. So we would have had healthcare workers that would have traveled and would fall into that a risk, having had a risk of exposure. We would have had healthcare workers who would have presented with influenza-like illnesses, any kind of respiratory symptoms that would have wanted to be tested. And then we would have had the healthcare workers through exposure, persons who would have attended to persons who were in fact COVID positive on the COVID positive wards. And then we also had where some hospitals just did general sampling of their staff within hospital. So we had different categories.
Can you tell us on that same slide, notified as opposed to tested? Because you have a discrepancy of 97 there. Could you explain?
Say that again?
Notified.
Notified.
Healthcare worker surveillance.
Notified.
Tested, negative,
Oh, okay.
positive.
All right, so this is on... Right. So the notifications are sent to the surveillance unit. These notifications would have been cases that have been brought to attention within the hospital, within the parish, and sent up. Now, based on the investigation, so every notification, if you are a healthcare worker and you think that you need to be tested, there would have been an interview and for us to determine your level of exposure, if there was any exposure or what. So 599 persons would have filled out a form to say, and based on now the level of exposure, testing would have been done. So we would have had 502 persons. So 97 persons essentially would have come to be tested, but based on our evaluation, you really were not at risk at all, and so therefore you would not have been tested.
Could I ask, just on those healthcare workers who presented with respiratory problems and that led to them being tested, there wouldn't be any double counting with the respiratory surveillance numbers?
No,
Okay.
because we keep them separate,
Okay.
because the ILIs are coming. There's a fixed surveillance that happens with ILIs and SARS and admitted LRTIs. So we keep them separately. We try to run our hospital care surveillance through our infection control units within the hospital. So for the surveillance of communities, that would have surrounded, in particular, communities that we've had clusters in. So in a parish, we would have picked up clusters of infection over time, and then you would have investigated the surrounding communities. And so we would have investigated 2,742 households, 9,757 interviews were done. Based on those interviews, we would then determine was there any kind of risk of exposure. 837 tests were done, and we would have had one positive arising out of that. And that one positive case would have been the case in Tivoli Gardens recently. In terms of the infirmary worker surveillance, 946 persons were tested, and again we had one positive person. In terms of the point of entry surveillance, right, in terms of the point of entry surveillance, we would have had persons that would have come by air and persons that would have come by sea. So we would have had 7,562 persons that would have come by air, and we had 107 positive out of that. And we would have 1,959 persons that would have come by sea. We would have had 45 persons out of that. And this was for the period April the 20th to June the 22nd. So the latest cases between 23rd of June to now, we would not have added those as yet. All right, the analysis has not been done, so I don't have the up-to-date information. But for those, we have a 1.5% positive rate. You can look, though, to say in terms of the, yes, go to the next one. So this slide would have been updated to a point where we had 181 cases, and this would have been the breakdown of those 180 imported cases. 25 cases prior to March 22nd, when we had the travel restriction. 8 cases from March 23rd to March 29th. 1 medical emergency on April the 16th from Turks and Caicos. And then from the controlled re-entry program, we've had this was 147 persons at the time, and 45 from the cruise ships, 18 from flights from the UK, 77 from flights from the US, and 7 from flights from Canada. I know that the last couple of positives we have that would have brought us now to 192, up from that 181, those would have all been from the US. So we can add those on to the US.
CMO, can you distinguish what you mean by controlled entry and controlled re-entry? Make that distinction, if there is one.
No, there really isn't any. We started out by saying controlled re-entry. Right, that's right. Yeah, because what happened was that we had persons that had left the country and would have been expecting to come back. And because of the travel restriction, they were not able to come back. And so there was a period of time when we were focusing on the re-entry of those persons. Subsequent to the 1st of June, it was entry, for it was not necessarily considering those persons that were stuck and needed to re-enter. So it really is just a little semantics, really, but...
Actually, I think it's significant, re-entry as opposed to entry, because there were Jamaicans there we needed to give priority to, because they were basically, as the CMO said, they were left without an option but to stay where they are, even though they had planned to be there for a limited time, and would have suffered a lot of inconvenience and so on. So the priority was given to them, and the terminology.
Yes, but what happened is that we have not really differentiated in the numbers.
Which is why I was asking.
Right, so I figured that's where you were going. We have not differentiated in the numbers who were the re-entry, although we know that for the first set of persons that came in, the first set was the IRMs that came in, and then we had a set of persons that came from Antigua, and then we had the cruise ship workers. And then after that, for about a week or so, we were just getting the hardship cases that were coming in, but we really have not differentiated in terms of the numbers.
Chair, through you, this slide, imported cases, relates to the point of entry surveillance in the previous slide, because it has the same positivity rate of 1.5.
It is.
Yeah.
It is the point of entry. Right. So
but the total is quite significantly different, because I guess this includes numbers after the 22nd of June. The 181 is more current than the 22nd of June, which was the cutoff date for the point of entry surveillance on the first chart.
Say that again.
All right. On this chart here, sort of summary.
Right.
You have 1.5% positivity, and you had told us that the data for point of entry surveillance was between the 20th of April and the 22nd of June.
That's correct.
Right? And then the one on the screen, which has the same positivity percentage for imported cases, has 181 as the total, whereas the number for on the previous slide, the point of entry surveillance, the number was smaller. It was, I think, 107 from air and 45 from sea,
Yeah.
which is 152.
Yeah.
It's a
very,
dating
yeah.
thing.
I'm very sorry about that. It's just because we would have done the analysis, full analysis up to a point. So I actually think that this analysis would have been at a point where we would have had 152 positives.
Right.
Okay.
Right.
But and then subsequent to that,
This
they
is
updated.
this is a more recent. I just want to say it's the same point
But
of entry thing.
But then the positivity rate, though, has essentially remained the same.
Yeah, it's interesting.
Right. So, as I said, the balance of the slides really just gives you a breakdown on all of that, which I've tried to cover in just speaking about the summary slide. So I would probably just want us to look of interest at the community surveillance that we did at Tivoli and Norwood, that we could go to that. So, and these numbers would have been added into the community surveillance numbers. So for Tivoli Gardens, our situation was that we had, in investigating the cases coming in, we had one imported case that we would have isolated. In doing the case investigations, we would have tested members in the household, and we had 4 persons that were confirmed positive. And so as a result of that, we thought the need was to do a community surveillance to see if there was anybody else that was involved. And the difference between, some people always ask, what's the difference between doing a community surveillance versus putting the community under quarantine? The fact is that these persons were without symptoms. So if it was that they were in their homes without symptoms, and we know that the likelihood of transmitting asymptomatic is a lot less than symptomatic cases. So at this point, which was 10 days, about 10 days, when we would have passed the usual period when persons would have become positive, which is usually about 5 to 7 days, then we thought if we looked throughout the community, if there was anybody that had fever or respiratory symptoms, then we would be able to pick up if there was any evidence of spread. So we went systematically from household to household. As I said, 268 households were visited, 1,200 persons approximately in that population. We were able to interview 721 persons to find out if they had any possibility of contact, if they had anything that looked like any respiratory illness. And in our surveillance, the 30 meters immediately around the house, we would have tested everybody. And then 100 meters out, we would have done a 1 in 10 surveillance. And then for this household, for this community, because we did not get the number of samples that we thought represented the density of the population, we went further and did an additional 200 meters to make sure that we got a good sampling of the population, considering that young people may move around a bit, and we just wanted to get a general feel. So, in total, we would have received back all our results, and we would have only had 1 person that was positive out of that.
Could you just repeat?
One beyond the initial 5, right?
What was it that triggered the need to do this in Tivoli? In other words, what happened from your perspective that resulted in, you said there was an imported case, right? But that happens around the island, so what was it that necessitated this effort to be undertaken?
Right, so...
What's the difference in the approach to Tivoli Gardens as against Anato Bay or Corn Piece? Because this is something in the minds of the public.
Sure.
That, same one case found, imported, locked down, but a different approach? Is it that, well, you could answer.
Yeah.
Let me not say.
So for Norwood, what we had were symptomatic cases. So when we did so we start off with a case investigation and contact tracing before we consider community surveillance, okay? And it is based on the result of that contact tracing that we find out what's happening, and then that would trigger another activity. So with the contact tracing for Norwood, what we found was that there were symptomatic persons, and that those persons were in different locations within a wider community. Anotobe, sorry, right. So we would have now have had a situation where we would have had a triangle of cases, a cluster being at each peak of the triangle. We had symptomatic persons, and they were moving around that triangle. That said that if these persons were symptomatic, there was a high likelihood that other persons could have been infected. And then those persons would have been incubating. Okay? So it now means that we need to stop. We need to stop activity here, and we need to check to see what's happening in the rest of the community. Are there persons who are symptomatic? Are there persons who would have had contact that we need to investigate? If our case investigation identifies that you have a cluster of cases that are without symptoms, then it means that based on the time period from they had contact with the symptomatic case, they would be incubating. So if they're incubating, then the likelihood that they would spread is low. Well, it's not. If they're incubating, they're not going to spread. They're incubating at this time. But you can't differentiate when they move from that incubating period to the pre-symptomatic to very, very mildly symptomatic that they don't even know that they have symptoms. So while there is a risk of exposure, what you're hoping is that you would not have the level of spread as when you have symptomatic cases. So you really, based on the time period and whether or not other persons who would have been exposed would be in an incubation phase or would be manifesting symptoms, the fever and respiratory surveillance is done. And that is what triggers a community surveillance rather than a lockdown where we know that you've had symptomatic cases and we know that they would have possibly spread. So it's a little bit of a, analysis of what's happening, the time period that has passed, and all of that we look at to try to make these decisions, what to do.
Sorry, I just want to ask if the approach that is now taking place, which is the stops and starts of the presentation, is it something we're agreed on? I'll allow the latitude if you're comfortable, but I want us to get through the presentation.
Well, I only have...
Okay, fine. But just to respond quickly to what the question that was asked. Right. It's really about risk, and I think that's really an explanation of assessment of risk in terms of the potential for community spread. All right, well, proceed then. I'll allow the latitude, given the length of the gap between the last meeting and this one.
Right.
So CMO, for example, in Tivoli, you have an imported case. What led to the other 4 related cases in the household being discovered and then the further action being taken to get the situation properly sorted out?
So every positive case that we get back, this person would have been tested on coming back into the country. And every positive case that we get, it would trigger case investigation and contact tracing. So that was done for this person and has been done for all the 192 persons that have been positive. And so in doing that now, we would have tested his family members and found that there were 4 persons that were positive. And then that triggered. So we would have pulled those out of the home, done their interview evaluation, recognized that they're asymptomatic, they're not having any problems, so we put them in an isolation facility, but then now we would proceed to find out if is there anybody else that would
So
have been
was that
exposed?
situation unusual? I mean, relative to the other imported cases we have, where you have the household having been infected and so on, or is that not quite common?
We've had, we don't have the slide today where we would have put up, you would see all the cases and then you would see all the clusters. So in most instances, and really and truly, what we have seen in Jamaica is that we don't have a very high level of spread. So we would have investigated everybody. So for example, the case that we had in Corn Piece, when we investigated that case, we found out that there weren't many positives at the time, but because of the level of contact, I mean, there were very, very close contact. There was a high possibility. We had done that close, small community surveillance, but the retesting had brought up some positives. So we had, so that is an obvious case where we would have had positives from the investigation, but several of the investigations, most of them would have not revealed any positives.
Of the number of cases that we have since the re-entry
Mhm.
to the entry program, how many of them, how many of the positives have led to contact positives? And did we do the surveillance to carry that?
Okay.
So is the Tivoli situation over now? I mean, is it finished?
No, usually a week after, the community health workers would go back in, not on a very obvious scale, but they would go back in and just speak with the community, find out if there's anybody that is displaying symptoms. Just like what we did with Anotobe, 1 week later, the team would have gone back in, see if there was anybody that was displaying respiratory symptoms. We did the same thing with 6 miles, 7 miles. Team would have gone back in 1 week later. Is there anybody? And then if there are persons, then they'd go back in another week later.
I guess the question that member Daly asked is, I think people want to have a clearer sense as to what are some of the kind of trigger points that would differentiate what took place in Tivoli or in Henwood from the other places where we are actually seeing cases.
It's in numbers. It's a number of cases.
The number of what? The number of
The number of
positive
number of
cases.
positive cases, first of all, their interview. So on their interview, we would have found out if they were symptomatic, one, and also what is their level of movement.
Okay.
You know, so we've had cases where we have had one case positive, and when we have done the case investigation, we would have found another person positive in the home, but they have not gone anywhere, and so we would not have had the need to do a full surveillance.
Are you sure that that one imported case, where was that case from?
For
The
Tivoli?
Yes.
You mean the address?
Yeah. No. Where was it imported from? The country?
He came from the U.S.
From the U.S. And stayed in the household, was tested where? At the airport?
At the airport.
Okay. Went home. But how do you know that that person didn't move around?
We don't know, and that's why we...
Okay, so you went in and you found 4 more positive cases in the household. The same household.
Right.
And you move out now, you 100 meters and your
Yes.
surveillance and thing. The point we are trying to find out, the same thing that happened in Hayes Corn Piece was one person,
Same thing that happened where?
Corn Piece Hayes, which is a what you call not as densely populated community like Tivoli Gardens. I mean, houses are far apart, not in high rise and so on, like
Right.
Tivoli. One case came in, imported, moved around. I think the gentleman had died now, right? Family members tested, but the entire community was locked down,
Right.
and
So-
several other cases found.
Right.
Okay. As I said earlier, in the minds of people and the questions of people have been asking, why the different approach? Why didn't you lock down Tivoli, quarantine Tivoli, as you did with Anotobe and Bull Bay and Corn Piece? I think that is what
Yeah.
citizens want to hear. what led the health professionals, what led the Ministry of Health to take a different approach. And I don't think they fully understand that up to now.
So it's essentially at which point the transmission is cauterized. For Tivoli, we had it just in the home, so therefore we would have done the community surveillance. For the other investigation, it was outside the home. It was 3 homes in Anotta Bay. In Cornpeace, it was 3 homes as well. So you have to think about the traffic between those homes, you know, to say that they could have contaminated somebody in between that traffic. You know.
I believe also, if I may, to venture in clinical territory, but from a social scientist perspective, which I am, the characteristics of the Cornpeace scenario as opposed to West Kingston, Lizard Town to be specific, is that the householder in question, the gentleman who was positive, had significant relations within that community. There are many houses that were related. There was significant movement between the houses and those persons, and because he was ill, fairly elderly, he attracted more visits. They went back into, so there are about 4 houses on that stretch that were like cousins and so on. So it really is a risk, it really is an assessment of the risk and the significance of the movement, and as the CMO said, the timing of the intervention. And what you do is make a call as to whether or not the thing has potentially spread based on the exposure levels. And I think that determines. Now, importantly, just to be clear, when you go in initially to assess, which is what was done in West Kingston and Norwood as the case may be, a determination is not yet made whether or not to quarantine. It's based on going in and assessing all of those things, and then you declare a quarantining of a community or not. And it took us a day or so, having got back the results of some of the sampling, you know, done the temperature checks of people, talking to people, that a determination was taken not to quarantine, having done the surveillance.
So you're suggesting, therefore, Chairman, that had the team gone in, did their checks, and of the 137 persons who were sampled, that we got a significant number of positives in disparate places, then a decision would have been taken then to lock down as opposed to just in a surveillance.
A decision could have been taken then, depending on if the assessment was different and the positives were different, yes. Put on your mic, please, thanks.
Yeah, if we had persons with fever
symptoms.
and respiratory symptoms,
Yes.
a large amount of persons we would have. Right,
How do you, I mean, we hear about the length of time it's taking to get the test results. Yeah, and, you know, a machine sometimes breaking down, you know, I've heard periods up to 12, 13 days and so on. When you have a situation like this, where you really need to get the situation under control, or at least know what the situation is, because it could be really bad if it was, or it could be mild. How do you have to prioritize the testing results? So we have
to prioritize. And again, we come back to the fact that, you know, the basic instructions to persons and the adherence to those instructions are more important than the testing. Because if everybody went home and reported when they have symptoms, then we would have picked up the cases even before we got back the test results. Because in both of these cases, the persons developed symptoms on the same day. So, you know, it really is the message. You know, we put a lot of emphasis on testing, and some people might say, you know, why it is that we would want to move away, because we can't keep up with testing everybody. And it's a 14-day period that we're interested in, when they, at any point during that period, they could develop symptoms. You know, so it's for that responsibility that everybody must know, or if I see somebody that has come back for them to stay in their homes, and if they develop symptoms that they have to report it, because that's how we really are going to be picking up the cases.
Just to follow up on that, you spoke about individuals not actually reporting in terms of the symptoms as they've been asked to do. I'm assuming that all of these individuals would have been tested on coming in, and they would have been on that COVID app, am I correct? And I just wanted to know what is it looking like in terms of the other areas of compliance now, in terms of staying home and limiting movement.
Mm-hmm. Well, in terms of where we want to go, the home quarantine period and the monitoring during the home quarantine period is really what is of utmost importance. What we have to consider now is the capacity of the health system to do that monitoring. And so where we are going now is we have been using the app for different things. The app has been used for geofencing, which is in terms of persons adhering to the quarantine order in terms of the restriction of movement. But where we're going to now is where the app persons will go on every day to document their temperature and their symptoms. And that there is a red flag, there's an alert that comes to the health department when you have positive symptoms or increase in temperature. And so therefore, if the health department have 1,000 persons to monitor in their parish, it's difficult for them to call everybody every day. And it's not everybody is going to call to say, which is what we'd love to have, that you call, because it's not all of them going to develop symptoms. But if now we have this tool where we can pick up the alerts on a daily basis to say that, okay, these are the persons that we need to concentrate on. We need to call them right away, say to them, isolate themselves, and we're coming to you. That's where we want to go in terms of the monitoring, because as the numbers get larger and larger, the face-to-face, which is important, just is not practical.
So just for clarity, because it's sounding to me that there are two, in terms of the monitoring, there are two areas that are important. Mm-hmm. One is physically where you are, mm-hmm, in terms of staying in place, and second is about the symptoms. Mm-hmm. And I hear you that we are not yet at this where you would like us to be, mm-hmm, in terms of how we monitor symptoms, yeah? Because face-to-face is just going to be impossible. So I hear that. But I thought that with the geofencing that we're doing, that we would have been able, through the app, to have alerts of persons if they are not adhering to the quarantine in that sense. And yes, I was wondering, therefore, whether or not the system would have been able to say to you what is the level of compliance there. Oh. And I'm asking the question because as we get more people coming in, it is important to know what, during this time, the home quarantine is like in terms of compliance, so we can understand the risk that we will be taking as we increase those individuals coming in.
Yeah, that's an excellent point. The data is there. We don't have that reliable feedback to us in health, and that's something, now that you have brought it up, it reinforces the fact that we really need to have that data to see what is the level of compliance. The plan is, and what has happened in some situations, is that when there is somebody that moves out of their zone, or this happens because people have reported it. You move out of your zone, it's a JCF that monitors, and they call. They call to say that we note that you have, you need to go back. If it is that there is an issue that needs to be reported to the health department, then they call the health department. We're having a real problem with this person, okay, and an intervention is planned. But in terms of the data you're talking about, we really need to get that to have the level of compliance with the quarantine orders. And really, it is something that is being done. So, we will trigger that reporting to us.
Okay. CMO, can you try and finish up the presentation now, and then
right.
we can continue the conversation?
Right, so the other slide is for Norwood, just to indicate what happened in Norwood. So we had situation imported who had 9 reported contacts. 7 of the contacts were positive. 6 live in one house in Paradise, Norwood, the same house as the individual, and 1 in Hendon in Norwood. And so we did the community surveillance here, and we did 64 households, 280 persons were interviewed, 165 samples were taken. We now have the 165 sample results, and we have no positive cases. We have no positive cases from the community surveillance. What we had another positive though that came out of the contact tracing. So we had a contact that had, subsequent to this 7, came back positive. So we had 8 contacts that were positive, but the community surveillance have not shown anything. But again, we are going to go back in that community again to do that surveillance.
I noticed that this slide before is dated 26th of June. The one on Tivoli. Do you have any? Is there any outstanding results that you...
No, all results are in.
All results?
Yes.
So you could actually say as of July the 1st?
Right, because the one that I have
Yes.
says that everybody is in.
Okay. What about Norwood?
Yes, all the results are in.
Very good.
Right. So pretty much the other slides really just covered everything that we have gone through in terms of the explanation of the slides. So I would finish.
I know there are other questions, but let me just put a little sort of guidance to the process. As you all know, members, that we announced a new set of orders for the next few weeks as it relates to entry, testing arrangements, and so on. And I really think we need to spend a little time to explain, both for the committee but also for public consumption. I think we have to spend some time to get the public to be very clear on what the new announcements represent in terms of nationals coming in, the testing protocol, and other protocols around homestay, as well as non-nationals and businesses. That would sort of complete the circle in terms of what is the current happenings. And then we go into some questions. Would you like to do that now, or would you like to?
Just one quick question. I think that's really where I'd love to go. I just wanted, in terms of seriously ill cases now, we've managed to keep our fatalities very stable. We've, thank God, touch wood. How many seriously ill people do we have with COVID at the moment?
We have 1 moderately ill person, so that does not require intensive care, but is sick.
Just a quick question, Chairman. I'm not sure if we have the answer here, and I'm prepared to await the answer. But I was wondering where we are in terms of the protection of our workers. I keep talking about that. The code of practice that is being developed for business. And I know that the standards are being developed. We're not sure what they are because we haven't heard them yet. And I'm concerned about what's happening with persons at risk who are at work, especially those with comorbidities. I know before we lifted the stay-at-home order, they were allowed to stay at home. I've been getting more and more cases of persons saying that they are being called to come into work, and they are concerned that they do have comorbidities and therefore they are at risk. I'm wondering how those are being treated. Also, if an individual is called in and is working but believe that the standards are not safe, what is their recourse? I just want to make sure, what is their recourse? What is their recourse?
At a workplace.
At a workplace, that they don't feel safe. I'm concerned because I want to make sure that we are protecting our workers and that they have at least some protection from the state, in terms of that. I mean, we don't want to go crazy, and we understand the level of anxiety, but where are we in terms of protecting our workers? I don't know if we can get the answers here.
So you're referring to the workplace protocols
Chairman, and especially our workers in the tourism sector, because my main concern is, as I look at what is happening in the United States, and particularly in Florida, where we have a lot of people coming from, I'm not a medical person either or anything, but I wonder if they have a more severe strain of the virus than we have here. And in coming into the island, we could be importing a strain. And how prepared are we for that if our own workers contract the thing? That is really my anxiety at this point.
Yes, Chair.
All right.
Please, just to add. The workplace protocol, is it published yet? Worked out with the Ministry of Labor and Social Security and all that? Reason being, as Member Brownberg said, I got a message from someone, 19 persons work in that office, and she was the only person who had on a mask. The only person. In this period, we have been able to hold the virus and manage it and control it to a point. I think it is critical and almost non-negotiable that the health protocols at the workplace established by the Ministry of Health be given out to businesses and entities, and that it be enforced. Our public health officers and public health teams must ensure that the protocols are enforced.
Right. So I'm going to ask the CMO or PS, either one, to just indicate the number of protocols that have been completed. The reality is that a number of industries or sectors, if you will, have asked for and are submitting specific protocols related to their particular environment. We have mounted a number of protocols on our website around infection prevention and control, and we have given guidance as to how entities or sectors should now tweak to suit their particular space. And then we have had some very specific ones like BPO, tourism, and others. And we have been working with the umbrella bodies, the PSOJ and so on, through an economic recovery task force appointed by the government. And I chair the resilience committee or subcommittee, and our report has been turned in, which will form a part of a larger committee. So a lot has happened as it relates to providing guidance, particularly for those places that have opened up based on announcements. That's one side of the coin. The other side is the enforcement, which a member spoke about. And that's where the surveillance component of the ministry is being boosted by engaging more community health aides and others, because we have to focus a lot on public education and enforcement, because frankly speaking, not everybody is complying. But CMO, you want to just comment on how many of those workplace protocols, or PS, either one, where we are in terms of those protocols?
Thank you, Chairman. Good morning, members. So overall, we have approximately 38 protocols that are published on the Ministry of Health and Wellness's website. Some of the protocols that are there are specific to the clinical practice in light of COVID-19, but quite a significant number of them relate to the operation of businesses and other social interactions within the society. The protocols are living documents, so we do review them from time to time based on changing knowledge, as well as reviews based on the practicality of application of the protocol in the space. I do agree that one of the challenge that we have, and it's something that we have to look at, is what if an employee goes into his place of work and is concerned about the adherence to the protocol? What is his course of action? And I think his or her course of action, and is something that we're going to have to raise with the Ministry of Labor and Social Security as to what is the protection that they have and what is the recourse they can exercise for their own protection. Yeah.
Okay, so CMO, can you just give us a very brief outline of the new announcements, particularly as it relates to entry, nationals, non-nationals, business entry, and in particular to the testing protocols around those activities? Thanks.
Okay, thanks, Minister. So, pretty much now, anybody that is coming into the country, for residents, they need to register on the Jam COVID site. And for non-residents, they are to register on the Visit Jamaica site. And they will get...
Sorry, you access one Visit Jamaica on the Jam COVID site, don't you?
No.
Is there a link to the Visit Jamaica?
No, there is a link to the two different websites.
But is there a link from one to the next? Okay, is that to avoid the confusion? Go ahead.
All right. So, having gone through the process on the website, you get a travel authorization, which is approval, and that has to be shown at the ticket agent before you can board the flight. So we have modified our risk-based protocols that will determine testing and quarantining of persons for the period starting July 1. And all persons coming into Jamaica will be subject to a health screening and risk assessment by the health authorities that are stationed at the airport. The protocols are that, the new protocols are that for all persons that are, let me just try to go through. So in terms for pre-testing, what we're now asking is that for non-residents that are visiting Jamaica, who are residents of locations designated as high risk by the health authorities, will be required to obtain a COVID-19 PCR test within 10 days prior to their intended date of arrival to Jamaica. Right. So all non-residents?
When they go online, they have asked some questions.
Right.
And the non-resident might say, I have asthma, or I have so-and-so. Is it online that is done?
Yes.
These,
so
yes.
there's a health assessment that is done online.
These questions are asked online.
For the authorization.
Right. And when those questions are answered by the prospective traveler, who tells the traveler to go and get a result?
So the traveler
to go and get a test.
Right. So
yes.
There will be a requirement now for you to upload your test result. So it's a part of the process. You will answer the questions and you will be prompted to upload. So the authorization comes after the uploading of the document.
And do all the necessary things. They will have to go and do that test before they can board the plane.
That's right.
Is that what you're saying,
right.
CMO? Okay.
Yes. So they will need to get the... So the authorization is also needed... no, it's not needed to purchase your ticket, but it's needed to board. It's needed to board the airline. It's needed to board the airline.
Information to the public, people abroad who are planning to come, that they know exactly what's going to happen.
PS, sorry, CMO. My understanding, and please shed some clarity on this for me, is that the intended visitor or person who's not non-Jamaican who is coming has to go on the app, answer the particular questions, is prompted to do a PCR testing, upload that result onto their particular documentation, and then they are given an authorization.
Right.
And that authorization now, they take that to the booking agent for the particular airline to buy a ticket to come to Jamaica.
Buy the ticket?
I don't think to buy the ticket, but to board the aircraft.
To board the aircraft.
Right. So they will be advised that you're going to need it to board. So that is on the instructions. So the person who is filling up the form will reach to a point where they have to upload. If they don't have it yet, then they're going to have to save their thing. They need to go and get their test, come back with the result, and upload it. They can't proceed.
So you, in terms of the high-risk areas, you rely on their representation as to their residency.
Sorry, can you repeat?
In terms of determining whether, in order to get their authorization, they must upload a certificate of testing showing that they are negative. And that is driven by whether or not they're coming from a high-risk area, which is residency-based. The system depends on their representation as to where they reside. So in other words, they would input, I live in Miami, or I live in, I don't know, Vermont, which may be not a high-risk area. I don't know which areas have been designated high-risk, and that presumably will change over time, or could, right? But as it stands now, what the system relies on their representation as to where they reside to determine whether or not they need to present a test result.
That's right.
That's right.
Minister.
Sorry, but a person traveling also has to log information in terms of where they're coming from and so on as part of their travel itinerary. It's normally a required field in terms of the information that you input. So there is the opportunity for some cross-referencing in terms of where people originate from. So it's while I agree,
you don't have to submit a utility like proof of address.
Right.
You don't have to do that.
No, but when you register with your passport information and your driver's license, as the case may be. But I do agree with you. There's no foolproof method, and you could have persons who fly to a particular state, end the flight in that state, and then book a separate ticket to fly to another to
if
Jamaica.
I may, Chairman, and that is part of the reason why one not only needs the clarity, but the truth is that it is our view that it should not just be those 4 states that you have. And although you say the situation is fluid and will change with time, but for example, I live in New York, and I drive across and go to New Jersey to where my aunt lives. I'm not required to present that as part of my, I'm not required to present a test because I am coming from New Jersey, right? Now, many persons, I'm not saying it is done, but run the potential for that to happen. So it is on that basis that ideally it should be the entire country as opposed to the 4 states in the country who would be required to do this. Because one is not only say that, Minister, the chairman indicated something that somebody may drive or take a flight to another state and then to book from there. It doesn't matter. The truth is that it is the country which has the greatest number of positives and deaths in the world, and it is something that you Chairman, may have to have a relook at and to determine, because the member from South Trelawney said clearly that she's not a medic, and she was speaking about another strain that is more virulent than whatever. I mean, we're not going there, but the basic point that the member is making is that there's a greater risk to us if all of these persons who might not be required to test come to the island, then the tourist sector, they take it home to their families and communities, and then you have a situation where you have to introduce another lockdown in the country.
So my response to that, if I may, from a policy perspective, is that we may well get there. I mean, we may well conclude, based on the risk assessment, that an entire country, in this instance, of course, North America, would require that level of screening. because as the member said, it's an evolving, it's a very fluid situation. But at this point, it was felt, member, that we would begin with this approach, and one of the positives, I think, of the approach of the government is that we have very short spurts of redirecting the policy position on 2-week spurts. So it allows us an opportunity, given the nature of the virus and how it is evolving, to respond. And if we have to do it in a shorter time, we'll do it too, because the public health expertise has the authority to influence those decisions on a shorter term basis. So we may well get there. At the same time, I think it's very important for us to recognize that testing is only one of several methods of screening an individual coming into the country, whether local, national, or non-national. No one is going to earn the right to come in solely on the basis that they did a PCR test 7 days before, or 8 or 9, as the case may be. They are going to be subjected to the screening processes that are standard at the airport. And in this instance, given the heightened state of alertness around this virus, the public health team will interrogate as necessary and test again if necessary. I mean, if someone comes in and they have a negative reading and they're coming with a temperature and symptoms, they're going to be pulled out and they're going to be isolated and they're going to be tested again. I mean, there's no ands or ifs about it. So the issue is a series of measures, which includes to a protocol at the hotels when they get there, both for staff and for guests. So I think it's important for the country to look at this in a sort of more holistic way, because if you focus only on testing, I'm telling you, we're going to make a lot of errors. And I think the world is trying to come to terms with that. Testing has margins of error depending on when the test is administered, when the person picked up the virus, how their body reacts to the virus, how fast the virus mutates and becomes visible in terms of a presence in the system. And I could go on and on. This is from my clinical reading, of course, not because I'm a medical doctor. And I'm saying we have to be careful we don't. I'm saying we have to be careful
Minister,
we
please,
don't
it's replicate
overemphasize.
instead of mutate.
Sorry?
I don't think we have mutated. It's
Okay.
replicate instead of mutate.
Replicate. Thank you. You see that I'm being corrected by a doctor, and I fully accept and take that correction. I don't know why the CMO never corrected me before, because I've used it a couple of times. The point, though, is that I think we need to provide appropriate levels of guidance to the country that the holistic approach is a sounder approach, and this is why the approach to surveillance is going to be very, very important going forward.
Minister,
All right?
I think it also needs to be clear that in asking the questions, we are not suggesting otherwise. We are seeking clarity, yeah, so that we can understand the process and that we can walk through it with you, so that it also provides clarity for those who are listening. And it also allows us to be able to answer questions when they're there. So, for example, I mean, we want also to be assured, I believe, that the surveillance is going to be as robust for the flights coming in, notwithstanding the documentation that is being asked for those who are tested. Right? Because, and err on the protocols established, why they are established, and that we are moving okay, and there's that assurance that people, the anxiety will be lessened. Yeah?
Chair, CMO, I have faith in the health teams and the quality of surveillance that they carry out at the ports. I have faith in port health. I have faith in, especially in times of crisis, that they are laser. What I'm not clear about is, and why I asked the question for us to get the clarity, is the reservation, booking, and travel to Jamaica. And that is what we want to have the clarity on, that part. I know airline will put in some protocols too. If somebody enters the airline with a fever and coughing, the airline might say, let me put the thing on you and see what it is. So we have to depend on other people too in the thing. And we do our part in our destination, Jamaica. But to go, I know there is some confusion about what you do, so that is why we are asking to go over it for us. And if any states, our tourism, majority of it comes from the United States, if any states have to do anything extra or special, then it be known. And let the public know, because people are calling, people are asking, including family members, what do I do? Do I have to do this? Do I have to do that? We want to come now. Now the re-entry program is open for everybody now. Let us go back through it. If we get one thing out of this today, is this clarity to the public as to what you have to do if you want to visit Jamaica.
So, Chair, just to understand, what I've heard so far is that there is a pre-testing regime applicable to anyone coming into Jamaica from certain states of the United States, 4 states, only non-nationals. So if you're a non-national and you're coming from one of those 4 states, currently then you have to upload, to get your authorization, a test result. You don't have to upload proof of address, that's not yet a requirement, but you do have to upload a test result showing a negative test, and that only applies to non-nationals. For nationals, or for non-nationals coming from other than those 4 states, what is the applicable regime?
All right, so I just want to say that in terms of the details of the procedure, in terms of persons, the tests being uploaded and being verified and all of that, these are still things that we are working out, and so it may change over time. We have a very small period of time that we're working in, and things keep changing. So, we have to depend on the technology and all of that to keep pace. And so we are working out that process. But I just want to re-emphasize, though, that what happens when the persons get here, okay? Because eventually we may reach to a point where that will be sufficient in terms of the evaluation that takes place when the person comes into country. So what is happening now and will continue is that there will be a health assessment. So the health assessment is based on certain factors. It's based on the age, the comorbid illnesses, the level of exposure based on questioning, the type of environment the person is coming from, the occupation, if there are any high-risk groups in terms of institutionalized persons that are returning. So if those persons, and there's a questionnaire that is filled out, and if there are any triggers that would label you as high risk, and we're also using the category of where you're coming from as well in this assessment, despite the fact of whatever has gone on before, if you've done a pre-test or if you've not done a pre-test or what, that will still be taken into consideration. Once a person is labeled as high risk for a Jamaican, then we are saying at present they need to do a test. For Jamaican, they need to do a test, and that test, what we are doing, Jamaican, for a Jamaican, okay? So that test, we are trying to move away from the airport testing, and so the appointments will be made within the parish that they are for them to do that test there, okay? So persons will be given either a quarantine order or a stay-at-home order based on the level of risk, and then they will be required to do the test. And we are hoping that we can get that test done within 48 hours. But again, I just want to re-emphasize that it's the adhering to the quarantine, as members have said, that is really what is important. People need to go home, stay home, stick to the infection prevention and control measures, get your test done, when you get your test, if the test result is positive, then you may need to be isolated, and that may be done at home based on the home assessment, or it may be that we're required to put you in a facility.
Chairman?
No.
Oh, sorry. No.
I was going on to the different categories of persons.
You want to just do that quickly, the categories quickly?
So in case of the business traveler that is coming to Jamaica for a short period of time, those persons we are testing presently at the airports. It may change over time. It's a smaller number of persons. We're trying to maintain some testing stations at the airport, and since we want to have a quick turnaround time for those persons to be able to carry out their businesses, we're going to be doing that testing at the airport. Persons will be quarantined in their place that they're staying until they get their test result, and then will be able to carry out their business, if negative, adhering again to the protocols that we have in terms of how you operate within country. For the person that is coming, the visitor that is coming and is going to the tourism corridor, those persons will be evaluated as well. They will have that health assessment. And regardless of whether they have had a negative test, if the health assessment places you at high risk, we're still saying that you need to have a test done here. Because your test, your negative test, might have been 7 days ago, you could have been incubating, you're still a high risk person, you need to have the test done. And for those persons, right now, as we try to diminish the number of testing we're doing at the airport, for right now we are testing some of those persons at the airport. But we are looking at what other arrangements can be made for this phase. And as the Minister has said, you know, the phases, it's a good thing that we have these periods that we can reevaluate, see what is the result of the testing, and then see how it is that we change. But for this phase, we are still saying that a test is needed, and right at this present time, the testing is being done at the airport, but we are looking at other methods of getting that testing done. We're looking at the utilization of private labs to do the sampling. The test would still come to the national services, but the sampling we believe can be outsourced. And we are looking at whether as well the use of our mobile units. We are looking at whether testing can be done within the hotel, looking at all different arrangements to see how best we can facilitate this. So those are essentially the main categories that we have.
So members, to be clear, 3 categories: nationals, non-nationals, and business. Those are the 3 categories, 3 specific protocols related to them.
Business is non-nationals?
Business could be non-nationals. Yes, no, it would be primarily non-nationals. Non-nationals,
so it's really recreational,
you see, the idea is that
recreational visit non-nationals and business non-nationals.
Right. They're coming into the country, they want to stay 4 or 5 days to do some business, take the sample, give them a quick result, they go about doing their business.
So just to clarify that we're talking about corporate type business. Personal business is treated in the same way as we would treat the Jamaican in terms of high risk, tested, quarantine.
All right, can we get some?
Thank you, Chairman. I'm happy that you have mentioned that she'll answer that after. We have a challenge right now, and part of it has to do with those who have come into the country, have done their second sampling after the 14-day quarantine period, but they have not received their results yet. And I would urge your CMO, PS, to have a look at that, because I think it's more a matter of what happens within the system, that the people have not been getting it. I've had many requests or WhatsApp and text messages to myself, as well as calls, that I'm at my 23rd day since I arrived in the country and my sample was done, but I'm not allowed to go because I don't have that second samples. So it is something that needs to be looked at. Secondly, CMO Chairman, there are issues related to complaints, if I may, from some hospitals that the sampling that they're not getting them back in time. So some of the surgery, as you have instituted the policy now where everyone is going to the hospital for certain things are done, that getting the results on a timely basis is what is critical. I want to ask the question, do we have any samples collected but not tested? Do we have any backlog?
Right. So at this time, we do have a backlog. As you say that there are persons that are waiting on their sample results. We have encountered a few challenges in terms of the supplies coming in a timely manner, in terms of testing kits. Okay. So essentially, a large amount of our testing now is done on the COBAS machine at the National Public Health Lab. And we have worked very closely with the suppliers and have been able to get in a large number of kits. Many of those, though, have been used up rapidly in this entry testing protocol at entry. Now, with what is happening in other jurisdictions...
Are those kits specific for the COBAS machine? Specific
for the COBAS, right. Now, with what is happening in other jurisdictions in terms of the number of cases, we are facing again the clampdown on supplies coming in. And so that...
Can you explain what you mean by the clampdown on supplies?
It is difficult to get supplies to come to Jamaica from countries of origin, because there is a need in those countries for the supplies, and so therefore they are holding on to them.
Just to clarify that terminology, my understanding is that there's a significant demand on the testing kits, and as more countries ramp up their testing, and so the suppliers... Sorry? Well, I mean, if you want to interpret it like that, we think it's one part of a full method of activities. No, so the challenge, of course, is to you kind of have to wait in line almost to get the supplies. So I think that's a primary concern.
Would you say it's a case of the antiviral remdesivir, similar, where we have been told in the media that a certain country has hugged it?
I didn't see that paragraph, but I hear you.
Right, but we have no. So we have put in other measures in place, because we use two systems. We use the COBAS, which is a closed system, which is a faster machine, and we're able to get a big volume out of that. The one at National Public Health Lab. But in terms of our machines that are at the National Influenza Center, we have an open system. The process is longer, right? So we don't get as much out of it. What we have done is that we've actually recruited 2 machines of that type, the open system, at the National Public Health Lab to do testing as well.
Machines from where? You have
so we have the machines there used for other testing purposes. Okay. So we're now doing some COBAS testing on those machines. We have COVID testing, on those machines. So we have ramped that up in terms of getting the capacity to do more testing on the open system at NPHL. We are also utilizing more of the PCR machines that are at the National Influenza Center to be able to get more testing done. The turnaround time is not as rapid as the COBAS, and we can't get the volume through because the process in terms of not just the processing time on the machine, but it's a manual, it's an extraction of the virus first, then you have to extract, and then you have to get it onto the PCR machine to do the test. So that extraction process takes some time, and it lengthens the process. But we have ramped up on that because right now we're getting almost 200 samples a day coming out of the university, and we're getting another about 150 samples on the machines at the NPHL. And this is separate from the COBAS. So once we get the COBAS back, the kits coming in, and we have some kits coming in today for the COBAS, but the numbers of kits, we're not able to get that, you know, in terms of being having a continuous flow of the COBAS kits. What we have done also, Dr. Guy, is that we have now asked the National Public Health Lab to all these in-house samples, in-country samples from the general hospital surveillance, from the contact tracing, those we are going to reserve one machine to just do that so that that process can continue. So we don't have a backup of the of tests that are coming in for general hospital surveillance, persons who are being prepped for theater suspected cases within country. They don't join the line. So we would have that continuous flow, and then we use the other machines to do the testing coming in from the airports. From time to time, though, we do have to prioritize certain samples, and so especially like how we have changed the protocol, we see what is happening in the United States with increasing numbers. We have asked for the first 2 or so days that we prioritize the samples coming in from the high-risk areas, just so that we have an idea as to what is happening now in those jurisdictions.
You did not indicate, if you can at this point, how many samples are in the backlog.
No, I don't have.
Okay.
I don't have the number.
Right. There are just 2 more questions I have. One is a comment.
I think I should also add that part of the backlog, which we have accepted and I've said publicly, I've certainly commented on it publicly, we're in a few days behind, is also downtime from the machine itself. And that's very important because it's not just about the supplies, and also downtime from just the fatigue on the staff. You know, I keep saying that I don't think sufficient persons appreciate the fact that prior to COVID, we were stretched and stressed, and COVID has added probably 50 or 60% additional requirement on the system without much additional capacity in terms of personnel. And so it is very logical and expected that after 5 months, you're going to get some cracks with the personnel, and some of those expertise are not expertise you can train overnight or recruit overnight. So it's really tough on the staff when you have to, yes, 2 labs in the first instance, UA and National Public Health, which is why we have started with some training with at least 1 lab, private lab. And again, there are limitations with the private labs. They are not accredited. Their staff needs to be trained. And we have done an assessment of these labs. We have identified 1 which is closest to being trainable, but only for the collection of samples, not for the testing, because they need more for testing. They don't have the machines, exactly. So they are now, and we're now doing some training there with the intention of having some support. But I spoke to the team that is doing that recruitment and training, and I was told that even within that organization, when the request was made for volunteers to sign up for this particular program, the take-up is extremely limited because there is still significant fear and stigma even within the professional groups around their engagement. And this is why our public health staff who are doing this are real heroes, because they have not thought about it. They just see it as their duty, and they have engaged. But there is a breaking point,
But
and we're
Minister,
struggling with that breaking point at this
thank
point
God,
in time.
Minister, the results from that we saw in the first major slide, thank God, the healthcare workers who have tested positive is a very small number. So at least you can say that despite the stigma and all that, the risk in Jamaica seems to be not that serious if they follow the protocols and do what they're supposed to.
Right. We have certainly been able to manage the risk, and that is worth saying. So I thought it was important to just give a sort of represent all the views as to why we have this backlog, and I really hope that the country would appreciate the circumstances and the context.
Right.
Thank you, Chairman. Sorry.
Right. I just want to say that, we have recruited staff from all over to participate in testing, and almost every group of healthcare worker has been involved in this process of, testing and processing persons, the thousands of persons that have come into the country and cases that have come out of investigation within country. I also want to say that the low infection rates that we're getting among healthcare workers is a testimony of the amount of training that we have had and the amount of sensitization and awareness that have been built within the healthcare workers. A lot of persons have spent a lot of time going around training and retraining in infection prevention control measures. And the adherence to the use of personal protective equipment and those measures is really what causes us to have a low infection rate among these different groups. So it's a lot of work that has been done by the healthcare workers, the same body of persons, but a tremendous amount of output, increased output than we would expect. A lot of persons working very, very hard in all the sectors.
Two comments.
Yes,
Chairman.
go ahead.
I too want to add to the comments made about the health sector workers. Minister, you will recall by one of your ministerial statements, and I was responding in the Parliament when I said that COVID has exposed the underbelly of the health sector, and you shook your head at that particular time. So it basically demonstrates that it was not good enough, but the whole thing of COVID has made and put greater stresses on the healthcare workers and those who are in the lab, and it is for those reasons why we commend them, because they have been doing your man and your woman service to the country. But I have a concern here. One of them is relating to your slide, CMO. I'd want you to, on your comorbidities. And I see the slide on comorbidities, and I said the last part you have psychiatric disorder. Well, 30% of us have psychiatric disorders, so I don't think it really should be there. Just saying that. And secondly, the concern I have, though, Minister, and I know it's all a case of priority. Are we, it's not are we are. There are some services that are being shifted with less priority because of COVID. I'm talking about the machines that we do, and the question I want to ask is about HIV testing and viral counts, because I'm thinking that you may have a challenge, because the same machines that you use for the HIV viral counts that you also use now for the COVID testing. Are we getting a displacement of those, particularly as it relates to the mother-to-child transmission program of HIV that we have in the country now?
So we did have some interruption of testing in terms of viral load testing, and we have been putting in different measures to address this. And I assure you that the measures that we are putting in is going to prevent any kind of interruption of treatment programs.
Sorry, on that particular note, what is, and slightly different, but the door was open, Minister. Where are we on the line of getting certified as a country?
Certified for?
In terms of our mother-to-child transmission. There are a few Caribbean countries that have been certified. Where are we? Which disease? HIV.
So like you're breaching the terms of reference of the committee.
I know, Chairman, but I said the door was open, so...
Let's close it though and move back to COVID.
Close it, CMO, please.
I don't know if she has that information
We can
offhand.
get that information and provide it
Right.
for you at our next meeting.
All right, we're gonna, folks, I want to move on to any other business, but we'll allow the member
Thank
to
you. So
ask his...
just a couple of questions. Could you please explain the difference between a quarantine order and a stay-at-home order, just for my own understanding, the difference between those two things? And secondly, I wanted to understand the notion of the bubble, the travel bubble, especially in relation to business travel. Is it possible for business people coming from very low risk countries, countries where there have virtually no cases and so on, can they come and enter without having to be tested and so on?
So the risk assessment that we're doing now to determine if persons need to be tested is going to be dependent on the health assessment, the location in terms of the community, and the location they're coming from. Right now, it's the countries that we have identified as high risk in terms of the number of cases that they have, and they're trending upward, that we're using. We are not, the countries that were designated bubble countries do not fall in that category, but the persons coming in from those countries will undergo the same risk assessment in terms of whether they need a test, whether they need to go into quarantine or what.
The quarantine order and the stay-at-home order, if you could just explain it.
Okay. So the stay-at-home order is that persons are required to remain at home and allowed to leave only once per day for essentials of life. And for those persons, when they are to leave their home, then all the protocols in terms of physical distancing and other infection prevention and control measures apply. That's a stay-at-home order. Quarantine order is that you have to stay within your home. No. That's a difference, yeah.
Yes, thank you very much. You have been so helpful today. In the bubble countries, how do you rate Cuba? I asked the chairman the other day, travel to Cuba, and you return. What would you have to stay at home or quarantine, or so? How do you feel about Cuba?
So with the change in the orders that we have, we're no longer using the bubble countries. Okay, so the assessment that is done now in terms of whether you need to have a test done is going to be dependent on your health profile, if you are coming from one of those countries that we have identified as high risk, that you need to have a pre-test from. That is the assessment that is being done now.
So, if I want to travel to Cuba, I just go and come back. Would I have to go into any isolation, quarantine?
Quarantine. You'd have to go in quarantine based on your risk assessment at the airport.
Based on the assessment at the airport?
Right.
That is, if I have the symptom, I have a fever.
So if you have symptoms, you're going in isolation.
Go in isolation. But I want to know if it is automatic that I go into quarantine coming from Cuba.
Yes. Yes. Quarantine. No, for the business traveler is treated differently. So the business traveler they will get a quarantine order that they need to stay in their hotel until they get their results. Okay? Once the result is negative, then we allow them to carry on their business, but they need to adhere to all the IPC measures that are in place and the restrictions that are in place for the country.
They get their results, so that assumes they've been tested then?
Yes, the business travelers will be tested.
Even from bubble countries?
Even from bubble countries.
Wow. All right.
Yeah, the bubble has burst.
Okay, thank you very much, members. Thank you, CMO and PS, for being here. I thought this exercise was necessary since we had such a long break between the last meeting and now, to give a fulsome update. At the next meeting, we will give our usual updates, and then I will have the NHF so we can focus on some of the expenditures, which was a request made earlier. We're at any other business?
Well, I think for clarity and transparency, not just the NHF, but at some point in time, we should also look at the funding for this exercise, for the entire COVID fight.
Right.
Prepared by the ministry to say this is what we have done, this is what we have spent, and so on. We anticipate the NHF at our next meeting, and then I believe, my opinion, we have to decide how long will we continue to meet.
Yes, well, what I'll do is ask the PS. That's easy. We have been providing information on spend. The Auditor General is actually in the ministry doing their own review, which we welcome. So we certainly would have that at our fingertips in terms of the spend. So what I'll do is ask the PS and NHF. NHF does a lot of the spend, to come and then give us, we look at finances and where gaps are maybe and so on. In terms of the length of the meeting, member, in terms of continuation, we will have to determine on that. I suspect that the management of this next phase of the process, which is more opening up, and the extent to which we have had to shift more to surveillance as opposed to restrictions, if you will, is going to pose a different set of challenges, and it may be useful for the committee to observe this for another period, maybe over the next month or so, and then make a determination. The question is, though, do we need to meet every week? So if we think there is a need for every week, I'm fine. I am going to add then to the circular the frequency of meeting. Any suggestions? Whether we do the Zoom or person to person in the parliament, and then persons can give their comments, and then based on the majority position, I'll circulate that. Is that okay?
Chairman, we had agreed that the meetings, the next two meetings have been the 2nd and the 9th, based on a circular that's gone on. I think we should be faithful to that particular one, particularly in light of the fact that the NHF and you, as you said, the PS will give us an update next week on the spend. Can decide, right.
After that. Okay, fair enough. So the next meeting then will be on the 9th at 10 a.m. and we'll focus on looking at the financing, and then we take it from there.
One quick, the field hospital at the arena, that's not going ahead, is
That's off the table, totally, right. All right, members, thank you very much again for being here, and meeting is adjourned, moved by Member Golden, seconded by Member Daly. Thank you.